lumbar spine. All right, so starting off just with some images for you identified. We have a couple of routine options for us as far as our orders go for spine. If you get a lumbar spine 2 or 3 view, this first option here, that would just be an AP, a left lateral, an L5S1. We refer to it as a spot. If they request obliques with a lumbar spine, you'll do those 3 protocol views and add in 2 posterior obliques using a 45-degree oblique. If they request flexion extension, watch the order. It can be done by itself or with the 3 views. So it might just be flexion extension. It might be flexion extension and a neutral. Or it might be the 3 views, AP, lateral, and spot, and flexion extensions as well. Reading orders is super important. Find out what they want. Trauma, we might have to use a cross-table method for the lateral, done laying down, unless they specify that it needs to be done upright. For AP lumbar spine, the correct position requires the patient to have their knees bent up. It reduces the lordotic curve. It also provides your patient with more comfort. The limbs extended, you can see the lordotic curve is higher. For AP lumbar spine, textbook has 2 different central rays. So if you're using a 14-17, they want you to center directly to iliac crest. For 11/14, and for us at our hospital, we use the 1.5 inches above iliac crest. Or find lower costal margin, which is your rib, and iliac crest, and go right in between those 2. You're going to use an SID of 40 inches, and this is done on expiration. You can see just the differences, 14-17 versus 11/14, centering wise. Evaluation. So you want to see from T12, which we can identify with having the last rib, and then you want to see all the way down to the sacrum, to the SI joints here. Please don't put your marker where this person put their marker, because a lot of back pain can be related to kidneys, and guess where this marker is? Essentially right on that patient's kidney. So please don't put it there. I'll show you where to put it. Lateral lumbar spine. So we do left lateral, but you may see some right laterals depending on the patient's pain. If their hip's in pain, I've done many right laterals. But we do left lateral just because it's easier. They're facing away from us. It's easier to palpate our landmarks. But we use the 1.5 inches above iliac crest. Again, same location. And the most important part before you do your lateral is to get the patient in lateral position from shoulders to pelvis. Get them lined up, straight up and down, their knees flexed, get them comfortable, and then center where you need to. Again, expiration. We don't use an angle, a tube angle on our lateral. We use a tube angle for our spot at our clinical site. So to reduce scatter on your lumbar spine, you can put a lead mat here in the back to improve your image. Criteria, you want to see from L5 all the way up to L1 and T12 ideally. Open spaces, the foramina are the circles, and we'll see those open here. But just spaces, L5S1 and then the sacrum. Trauma lateral position, if your patient's on a stretcher and you need to do a lateral lumbar spine, you can simply wheel them up to the wall bucky and shoot across. You will have to increase your SID to 60 inches because the tube hits our stretchers at 40, but it's the same centering, same thing. Your L5S1. So this is going to be an 8x10 cassette. We do not use these block supports at our clinical site, so you won't see any of that. But centering wise, your tube angle is going to be perpendicular to the interiliac line. What does that mean? If you were to draw a line on the tops of their iliac crest, does their pelvis look straight up and down? If not, you're going to add in a tube angle, going caudad down, like this. Okay, if the interiliac line is like this, caudad angle centering down here, usually 5 to 8 degrees. Okay. What are you going to see? You want to see a nice open space between L5 and S1. Is it open? Yes. If not, then you either don't need an angle or you need more angle. Oblique lumbar spines may be ordered. We don't do these too often, but at the offsites I'm sure that they do them, and I'll show you how to do it in lab. But they're 45-degree obliques. You want to make sure the patient rolls like a log. What does that mean? You want them to roll as sort of a unit. You don't want them to sort of kick their hips out and get their shoulders out of alignment. You want them to sort of move completely in the same sort of speed as well. So you're going to oblique them up 45 degrees. I use this triangle block sponge from their shoulders to their hips, ideally. Center to L3, 1 or 2 inches above iliac crest, and then 2 inches medial to upside ASIS. So find the ASIS on the upside, 2 inches medial. All right. Evaluation criteria. So you're looking for your what we call Scottie Dogs, and I think I show you those to you in a picture in a second here. But you can see the eye of the Scottie Dog. You want it sort of midline to the vertebrae here. The zygoapophyseal joints. These are the joint between the superior articular process of one vertebrae and the inferior articular process of the vertebrae directly above it. And we see those in the obliques. So the zygoapophyseal joints are at a 45-degree angle. You need to memorize what you see on a downside, or what you see on posterior obliques is the downside joint. Anterior obliques are the upside joint. Even though you will probably never do an anterior oblique lumbar spine, for boards, they want you to know this silliness. So keep that in mind. We do posterior obliques routinely, so you're going to see the downside joint. But it's simply just something that you have to memorize. Scotty Dog. Know the parts of your Scotty Dog. Know the anatomy of your Scotty Dog. Okay, so the ear, the nose, the eye, the neck, and the leg. And then you want the eye of the Scotty Dog, so the pedicle here, this circle or eye, you want the eye of the Scotty Dog to be in the midline of the vertebrae itself. If the eye is too anterior, that actually means it's not enough oblique. If the eye is posterior, it's too much oblique. And that'll take a little bit of time to recognize that and to be able to figure that out. But the nose is your transverse process. And if you think about the view where you see the transverse process the clearest, that's AP. So if the nose is too far forward outside of the vertebrae, that means you're too close to AP and you're not enough oblique, if that makes sense. All right, so this is just another visualization of the Scotty Dog where it should be. And know your parts. This is showing you the zygoapophyseal really clearly. See this nice line here right in between. Okay, I'm going to stop there and I'll pick back up with you guys.